Good morning and welcome to this live show today on Center Stage, The Tackle. My name is Pheona Kenga, and today we are actually going to delve into the issues of moving from NHIF to SHIF. And just a bit of a recap of what we are going to be talking about. Social Health Insurance Act was declared unconstitutional in July because of lack of proper public participation, and that was by a 3-bench judge that has suspended it for 120 days to rectify the illegalities. Now, today, we're looking at both salaried and unsalaried members of the SHIF that will make a monthly contribution of 2.75% of their income to the fund. But today, what does Kenyans or the Kenyans stand to benefit from this movement from SHIF, from NHIF to SHIF, starting the 1st of October this year? Today, I'll be introducing my guests in the show, George Maroah, the Secretary for Kenya Union of Clinical Officers. Karibu sana, habari yako?
Nzuri sana.
You're good this morning? Karibu sana. And we have Dr. Kahura Mundia, who is the wakili daktari, but also the Deputy National Chairperson KMPDU. Karibu sana kwenye show.
Asante sana.
Uko aje asubuhi ya leo?
Niko mzima kabisa.
And today we are actually talking about Social Health Insurance Fund. There've been a lot of uproar on the social media. I don't know, maybe is it because we lack civil education when it comes to knowing the actual benefits and even reading this act and knowing what it actually would benefit the Kenyan mwananchi?
Mm-hmm. Well, it's a new thing.
Yeah.
And not many Kenyans are aware about it. Mm-hmm. Reason being, it was done like 3 weeks.
Okay.
And the laws were made, and since then, there have been a lot of cases going up. And not many Kenyans again have been onboarded, and as of last time I checked, I heard there was about maybe 500,000 persons who had registered. Mm-hmm. So we're yet to get the threshold for it to be known that this is what it is, and we've shifted from NHIF to the Social Health Authority, now which now goes under the name of SHIF. Mm. So maybe as time goes by, we will get to have enough persons onboarding. Mm-hmm. But that will cost us, because in operations management, you either choose the vehicle you work with, either improve it because it's well known. And you've had about over 50 years of it being known as what it is about health financing. Mm-hmm. But now going to a new system always has its challenges. There is acceptance, there is onboarding, there is operation, there is marketing.
Okay.
Now we'll be spending a lot of good money to try and do the same things that we used to do. Mm-hmm. Because in my view, the benefits are still the same, just a little bit enhanced. And NHIF previously was still enhancing, and it was the journey of just enhancing to become the best thing that it's supposed to provide for Kenyans. The digitization aspect, in my view, again, NHIF was still digitized. So the things that we're going to, they look good, yes.
Yes.
And just like they've been saying, that it's a rebrand, it's an upgrade of NHIF, so we should accept it. Yes, we are accepting. And we just want to see that it works. And if the going becomes too steep from a management point of view, the best way will be just to repackage the new things on the other way and tweak out the operational inefficiencies, the corruption issues at NHIF, and still have your vehicle moving to where it's supposed to go. Because the spirit is to deliver healthcare financing to Kenyans. So that will be my perspective on status where you have limited resources. If you had plenty, then you can rebrand, you can push, and you can even plan for like 4 years marketing strategy plan. But it's a journey that we have to do it together. Because we all deserve healthcare.
Okay, Maroah, do you believe that SHIF will actually positively impact Kenyans, especially in delivering or accessing healthcare and also financial protection?
Thank you. I think let me be very specific that history is key.
Yes.
Now you want to do like a total uphold or rather change in terms of like the social fund that we are introducing, where there is a shift from now the National Health Insurance. The National Health Insurance Fund, when it was started purposefully, it was targeting those who are in informal employment. And then later on, actually by that time, again, even when it started, they were paying only for beds. And people started complaining that I need medication. It's not about the bed, I have bed at home. So then they improved it. They started now covering some part of the services, and it has been growing. It went to the private sector. Now it came to, it had been open to everyone. And remember, when we talk about shift being mandatory, the provision under NHF is also mandatory. Did we implement? No. So how will we implement the mandatory side of this side? So then we had a fund the other side, and we have a fund this side. Because of that, it must be progressive. As NHF has been, it has been progressive until of the recent past with the previous government. We had introduced a number of other, that is to mean additional funds. Like for instance, we introduced what we call the Maroah. We introduced the Edu Afia. That's some of the benefit that we were bringing, government trying to look at who can we support. Did we have a proper legislation to support all those? I think it's because of the tweaking in terms of the law that we had then. It allowed and accommodated that. So looking at that, then the feeling has been that there have been a gap after the constitution, because the constitution provided mandatory that the national that the state has a responsibility to ensure that every Kenyan can get the services whenever they need it. More specifically on the emergency services, which it had not been functional. So then, when they are coming with a new act, that's the SHA, there is now a provision for 3 funds.
Yes.
And the 3 funds, that is the social health insurance funds, the emergency and the critical care funds, and we have the primary care funds. And when you look at it, largely is that the government is going to be the one, we are going to use from the national kitty to fund these services. The primary health care is exclusively going to be funded by the government. That's our tax.
Yes.
Then similarly, the
emergency and chronic illness.
But again, also at the social well, where there is now, that's where now you have the membership. Still, there is those we call indigents. The government have to pay for them to sustain them at that level of the social health insurance.
And do you feel like the government will be able to do that?
If I come there.
Okay.
So then when now you look at that, is that already the government is committing to be doing that. When they commit to do that, there is a provision that's saying mandatory for you to get services. Like now where we were, how many people have we imported or rather registered for us to ensure that the smooth services is running? So when you say it is mandatory for you to register, registering meaning you have now to continue paying or subscribing for you to sustain your embodiment or rather your registration. Or the government, if it has now embodied the people they call indigents, so that's how they sustain you on the register. Because failure to do that, then services is not there. Just last week I was from Botswana. Botswana is provided you are a citizen. You introduce your card, you don't need to be registered. So they give you services. I've heard even the chairman saying that the reason why we must import everyone for them to get now the services is because there are other people who can cross over. How? They cannot identify themselves. We have a unique way of identifying Kenya. So we can use that system also to ensure that services is going to be offered. So they say if you don't pay, they call it erratic payment, where you just, when you get sick, you pay so that you get the services.
Yes.
Then they are trying to avoid that. So for them, the premeditation that they have is that you must have been paid up for you to access the primary healthcare services. But already the constitution dictated that you cannot deny anyone a service, because the government has now declared it is going to do it for free. So if it is for free, you cannot deny anyone a service at that level, because already you are using their taxes. It is our money. It's already our tax you have taken from the other side and invested here. So there is no way they are going to do it to deny our services. Now, your question is the government going to afford?
Yes.
If there is a goodwill, the government can afford. because if you look at the Abuja Declaration, we need to see a proper budgeting and allocation of resources that can help us deliver services to Kenya, because it's about accessibility, it's about actually ensuring that we caution people from the cost of medication. Now, with the way we have started, I'm worried because there is no clear projection that indeed they intend to do it. The policy is good, the projection there and the stipulation are very good, but unfortunately, if you look at what the last budget, I think, which has some issues, has projected, is that they asked for 50 billion for primary healthcare.
Yes.
The allocated money, according to the budget, is 4 billion. So what is the percentage of what had been asked? We know that to functionalize the emergency bill, the emergency and critical care, also it had been approximated around 100 billion.
Yes.
So what are they going to get there? Then similarly, on the other side, it depends on the members that we import. Then on the social health, that's where now you'll have to wait until I'm a member, then that's how you can be able to get the money that you want. But they are already projecting to raise close to 250 billion on the membership and the indigents. So where we are still worried that there's no proper measures indeed to influence, or rather to inspire us and give us hope that indeed this government want to implement the policy, or rather these act as they have provided to us.
What could be the legal challenges that maybe could arise during this transition from NHIF to SHIF?
Well, currently, as per what was done last year, that September to October, you see, the government wanted to launch the whole spirit of what they had put in the manifesto, that they want to make reforms to the social health insurance scheme or provide a sort of healthcare financing for Kenyans. And again, in alignment with what the Constitution provides. Okay. So the issue was the speed and reaching out to persons to make sure that persons' views are consonanting with what the government is proposing. So that lack of consonance is what is now the public participation, which was void. And because of that, the courts decided that the laws have to be given more time so that the National Assembly and the Senate has to go down the ground and meet people and hear their views as to what they want in all this. So that is now what was suspended for 45 days, which lapsed, I think, last week. The first 45 days lapsed, and that means now the judgment is enforced. And between the judgment to the end now, that's when you're supposed to get the new laws coming up in the 120 days. That's around November 26th. But again, there was an appeal that the judgment should be stayed, and the spirit of what the government needs to fulfill, which is to have social health care financing being achieved, that they want a stay. A stay is like a suspension of the judgment so they can have more time to roll out, probably more time to either do public participation. So I don't know whether that public participation now will be in form of marketing, at the same time infuse it with conforming with what the law is supposed to be. So those aspects of not having most of the bits of the law, the four laws, that was the primary health care law, the digital health law, and the social health insurance law, conforming with what is in the Constitution. Once that is done, I think they should be in a good way to run away with it. Then there's the regulations. There's the general regulations. Then there's benefits and tariffs regulations. And I think there could be other regulations regarding dispute tribunals. That's issues of conflicts between the providers and the patients, or providers and the social health authority. So that tribunal is supposed to assess, hear out the cases, and just try to have seamless operations at the authority. So it is doable. So the issue is now acceptance and persons knowing that this is an extra. See, now there is that rate that has been tweaked. It used to be about 1,700 maximum capping. So this 2.75%, most Kenyans are still, and the way the sense of the economy is, they're still feeling this is too high.
It is.
So if it's too high, they feel like it's another extra tax on top of. You see, we pay about 50% in form of taxes, the VAT, the 16%, the pay as you earn, and the other forms of taxes and levies all over the place. So if you accumulate all this, it becomes too high. So you add another 2.75%, so it becomes about 52 point something. Then you take home 48% as for salaried persons. So if you feel that the benefits that you're going to get, see, it's like a product you're selling. It is government public goods, But now, if the product is not rhyming with what you're paying out for it, you feel like you have to just reject the whole package. And that lack of acceptance is what is making persons not joining that fast as expected. But it is mandatory to join. So now persons will probably have a dilemma whether to still pay up for it, pay as much, and if the services they're getting from the packages are not that sufficient, they'll feel aggrieved. Now, point to note is that for the dental, I've looked through the benefit packages that were being validated the other side, the other day on 30th at KICC. They have proposed that some of the benefits will not be rolled out in the first months, in the first few months, or in the first few years of the program. But it is going to be a little bit disadvantaging because you've contributed a lot. For persons who are probably high earners, they'll be paying towards about 80,000 towards 100,000 in a year as premiums.
Yes.
So it's as much as what you pay for a private cover. But if the cover is coming without your full catalogue of benefits, you feel shortchanged. And notably, dental services, I'll be on record that these have not been provided for. They've not been costed. The stakeholders have not been listened to. And if they have made some presentations.
And what are your concerns?
And they have not been taken in. What the authorities or the persons designing these benefits at the instance, they are saying that they don't have enough data to model the benefits that are supposed to be rolled out in terms of dentistry. And that they feel like the best way is to watch first. I don't know what will be happening as persons are watching, because toothache, everyone has teeth. And a lot of cases are there available. So they should at least design a benefit of basic benefits that are available at all levels, like they say level 1 all the way to level 4 or 5, at least on the minimum. Just try and mop up the need, because if the needs are not checked in the cover, acceptance becomes a little bit challenging. That will be my view.
Maroah, okay, you have something to say.
Let me say this.
Yes.
I think when you look at the motive and the reason why we were coming up with the new legislation was more of to push for a paradigm shift from what we call curative services and actually offer a funding structure for primary health care, so that then we can increase service provision and access to services. Ensure that those who have not been able to access services can access it. Look at it. How many people what is the percentage of the membership under NHF? It's around, the highest it has gone is around 24%. Actually, not even just NHF, all people under a form of insurance. So, and that has been going, it goes up a bit, then it comes to 19%. So is that, that's to mean a majority of Kenyan have not been enrolled in any form of insurance. So then that can be the only, then when you look at it, then when we were doing this, is that we know why we were doing this shift. So we must not really slumber, or rather make a lot of mistake when we are starting. We must impress people, and impressing people is by ensuring that they appreciate the services that we want to offer under the SHA. So that then when Dr. Ari talk about progressively, yes, I want to have everyone onboarded.
Yes.
When you want to do that, I don't want to use where I come up with a statement that probably cause a rift and probably resistance from Kenyan. You have to ensure that you entice them by services. If you offer good services today, everyone will run there.
Yes.
When there is, I want to give a good example, like you'll have most of the public primary schools around, and there is one probably which is private, and it is presumably, they believe that it's doing better. Everyone wants to take their child there. So if then we are doing better, if SHA can do better, let me tell you, even it will be very difficult for any private insurance to run, or rather to operate within the state. So for me, I'm looking at they need to look at the optics. What is it that really driven us where we want to go? Do we still have that, do we still hold that indeed we need to implement that law? And how can we do it so that Kenyan can be able to appreciate? So then, we know that we cannot, for the first thing, I know as a medic and as a practitioner, is that we cannot onboard more than what we used to have immediately and have all the services running immediately. It will be progressive. But again, it will be catastrophic for me to take away the benefit for those who had already experienced a benefit to a certain level, and then you take them back. That one you'll get a lot of resistance, and that is where, like, we the healthcare workers who are more exposed, because then this is where we take leverage. We feel that if you take away the benefit that healthcare workers are getting currently, we are not appreciating, and we cannot. And indeed, in the labor movement, you cannot take away already what people are getting, and you more of re-engage on the same and give them a different package. That is where we normally experience resistance.
Maybe if I could ask, how do you think the shift will actually affect referrals?
Referrals, looking at it, if it is implemented, by the way, it's going to streamline referral. Because currently the way it is, the referral system is broken. It is not functional. Because you find someone walking away from Adar and they get to line at KNH seeking services. It's not how it's supposed to be. As it is, it actually more of structured now under the SHA is that you have first, if you are sick, access the lower facility which is provided under the primary healthcare funds first before you come to access the social health insurance fund. Unless there is an emergency, that's when now you jump to any facility, because then the emergency and critical care fund normally have to offer services. So if that one will be functional, then we'll be able to appreciate. But as I've said, we already experiencing shortage in terms of funds at the primary healthcare, where the government directly is supposed to provide enough fund to ensure that we function as services. Because why is it that current people do not trust those lower facilities? Because I go there, there's no headache, there's no medic. If there is a medical, rather health staff who can give me services, the laboratory is not functioning, or there is no drugs, which is a cry like what I was seeing even yesterday in Machakos. Most people have to go to those hospitals, they get consultation, and you just get a paper to go and buy drugs. So you have spent the whole time in the hospital. By the end of the day, what relieve your pain or treat your disease, then you have to go and buy. Where probably you do not have that money. We want to anticipate a situation, we want to see a situation where government has properly organized itself to ensure that they are offering services that can actually itself sell hope to Kenyan. Because if I come to the hospital and don't get that services, I've spent more than the whole day in that hospital, I don't have hope with that hospital. Yes.
Yeah. So maybe there's something Maroah talked about, corruption and maybe mismanagement of the fund itself. How can this be protected as a legal person?
You talk about the NHIF fund now. Well, all funds in Kenya. Even the treasury, monies are looted everywhere. So I don't know whether there is any money that is stored anywhere that is
maybe the legal mechanisms that could be put in place to ensure that these funds are not mismanaged.
Well, the only way is to have a system whereby from the time you're raising a claim, so most of the funds are either lost at those are different places. Funds that are lost at management level because they have an excess spend as management than what they're collecting. That's loss of different kinds. So there is now the other loss that is attributed to providers, which is somehow usually used to mask the whole picture. So there are providers who are fraudulent, and there are other persons who are not providers but are still in that chain. So let's look at a hospital setup whereby you're having a claim being raised. There is a pre-authorization for claims, and there is a other type of system whereby monies are paid in advance for persons to attend a facility. So the monies that are paid in advance, you can have persons or facilities with ghost patients. And money is paid in advance. So it's like delivery that is happening in advance. So they have to have a proper system to vet out that all those persons who've probably selected a particular facility exist. And that's why they were suggesting that they're doing new registration to mop out the possibility of ghost persons in the system. So I asked, why were they forcing persons to register new, and why would they not just port out the old database to the new system? So they say they want to validate the occupants of that old database. Well, that could have been done without another registration, in my view. That persons could just be sent messages to self-validate or verify and move into the new database. That way you remove out the ghost persons, because you have facilities which have a lot of persons who have probably not selected those areas, or fake persons who have selected those areas. So who is registered where? You can probably minimize fraud on that aspect of capitation. Now, on the other system of payment of services is the pre-authorization, whereby you visit a facility, you are informed that these services, they're catered for, but they're forms that you have to fill, and then you submit them. And then at the end, there's someone who sits to check whether this claim that has been sent is valid, and it's whatever it's stated is signed by the doctor. The doctor is a real doctor. The doctor is registered and qualified for those particular services, because previously you had persons who were not doctors signing off paperwork and imposing out as doctors, using other doctors' numbers and imposing out there like their providers. You have fake conditions being registered on that. And the persons who are vetting, again, these are weaknesses that were there in the NHIF system. We did not have doctors to verify these claims. We did not have enough nurses, clinical officers to verify all these claims. We did not have dentists or pharmacists. So claims will be processed by persons who are just like clerks. So it's like giving a very technical job, which is very crucial. It's a person who's like checking how much you're spending, and they're not qualified to know what is what. So if you don't know what registration number that is, what procedure that is, what other alternatives that could be, that procedure could be vetted out with, you'll end up overspending on claims that you don't know things about. And these are operational issues that NHIF or even the SHA could be able to do if they have enough competent persons behind the scenes to look at those claims and process them and pay out. Now, what they are proposing in the new law is to have the function outsourced to private entities. Now, I don't know how now we fuse public money being oversighted by private bodies. Now, private bodies have interests of their own, and they have businesses elsewhere in networks. That's my own assessment of how things are run in Kenya. So tenders will be pushed out of private verifiers of claims. Then they'll sit behind the scene, they look at the claims, then they'll validate which claims to pay for. Now, in the system of corruption, if you want to pay claims in a particular direction, you'll close your eyes where you don't want to and channel your funds to the facilities you like or where you have interests are, because you're supposed to probably operate with no conflict of interest, but I don't have to show it directly.
Yeah.
So I can have other persons working with me behind the scenes, and you will never know where that is. So this aspect of corruption being tackled now under SHA, to me, still appears like a mirage. And the private sector managing public funds, it also looks a little bit hazy, because in my view, it would have been a closed system, whereby the claims processing authority or department or unit is put in-house. It has competent persons who are answerable directly to SHA, instead of like introducing a tendering system to try and manage that, because you see it's too complex, we are going to be too inefficient, let's just outsource it. It's like a SHA running on different tracks on the same system. So we're just over complicating processes, and in my view, these hurdles will come out to show up in the future. You've seen the issues of what has happened to TSC, the police systems. Their covers were all outsourced. So SHA could provide enough services and good ones. We still have to have some ways of doing it. The only thing is that the experience we've had at NHIF is all being, I don't know whether it's being taken up into SHA or it's being properly saying it's new. Let's forget the experiences we learned at NHIF and shift to SHA and continue. So we wait to watch and see. That's the situation.
Very interesting. I think that's one of the key issues, and I mentioned it that contributed to lack of trust, loss of funds, public funds, members' funds, which is intended to offer services, and it is lost with a few people. As the Kari talk about it, my own understanding is that indeed fraud is created, and the system is as good as those people who operate them. So when I know about that, I know that there is gaps in terms of the administration of the funds, what we call governance system, which is weak. The collaboration, the stealing at the NHF has been more of a collaboration effort between the administration and also the workers, the service providers. There is no way a service provider steals directly without a collaboration from inside.
Yes.
So that's where the system was totally rotten. even where maybe I have someone who is approving, who probably might not be a medic, people will have an eye if there is no agreement into that. Where you have a facility, including government facility, purporting to do certain procedure, which they have not even able to do, they have not done, and they make claim to government. And I can make a very specific cases which I know, like for instance from Kisii, that Kisii up to date as I speak, even a CT scan does not function, but they have been claiming money that they are doing such a function to Kenyan. And this issue has been under investigation by even CID, but no one. The issue we have is that you can see money being stolen, there is fraud outright, but investigation start never ends. So the culprit are never held responsible. No one has been held, or rather been actually found guilty of such a thing. Let me give a good example. For instance, when Geoffrey Mwangi was removed from the position of the CEO, he had been accused of close to around 7 billion. He has been cleared of the same by the same court, but money was lost.
Money was lost and never recovered.
Yes, never recovered. So as we talk about maybe digitalizing to ensure that we can eliminate ghost workers. Who created the ghost workers? It is the administration. Ghost workers do not bring themselves in the system. It is people seated there, they create ghost workers for purpose of stealing from Kenyans. So for me, I will still say that what we call for is a process where discipline must be upheld and integrity among the peoples who are serving Kenyan. If you indeed you have been given an opportunity to serve Kenyan and you are stealing from Kenyan, what the best thing that we can reward you is to hold you responsible, return our money, and be put to sale. And you wrote there, so that then you serve as a good example for others, to deter other people who might be having. But if I steal and I'm the same person who is being glorified, being taken from this institution to this institution, then you must get to understand that even as as when we claim that I'm the one who is stealing, there could be even more cartel than I do, higher than me in ranking. So let me say that up to date, the SHA has not demonstrated indeed that they have any other measures that they have put in place to ensure that they can actually do away with the fraud in the funds. And as he has talked about the issues of bringing the private manager to run the funds, I think that also brings a lot of worry in terms of accountability, because those measures have not been put in place. And that is some of the issues that I know, like us as professionals, we said that this is not supposed to be. Because then, if this is our public fund, it has been deducted, this money can actually be held at even Treasury. The Treasury do that service to hold the fund. So the others to run the claim and ensure they process those claims and approval of services, so that then the payment be done by Treasury. So that money we can trust that we have Treasury, that if money is stolen, it's at Treasury, not at bringing private entities that can get lost, because we know that that has been happening a lot.
Maybe,
so
okay.
I could add a little bit more. So you asked what we can do about corruption.
Yes.
You have seen the investigation at the Parliament has an oversight role on all.
But are they really oversighting?
Well, once in a while, when there's stories they do.
Yeah.
Last year, after there is, I don't know whether it was engineered. Sometimes you can also engineer a case to push an agenda, so that hospitals had overbilled. How much was it? Do you remember? But the National Assembly Health Committee sat down and they have released a report that there was fraud in particular facilities, and there were issues with how the claims were being processed. And proposals have been suggested on what to be done by the NHIF authority. So I think from that report, I think that issue will be taken up by the SHA authority and follow up on it. So Senate and Parliament have that oversight role. There's other part where now we can have operational back checks, like have post-authorization claims checks, Once payments have been done, just follow up with patients and check whether whatever was stated was done or was paid for in a way that is fair as what was postulated there. So having such ways, you can try and mop out claims of fraud that have happened in the system, and then try and just do a lot of civic good and just educate the public that this is your money. Stealing from yourselves when you want yourself to benefit from it, it will not work. Because as you understand, public goods benefit all of us, the payers and the non-payers. Just the same way we have roads. Those are made from taxes. The public street lighting, it's from taxes. So, but if these allocations are too little, they will not assist Kenyans. And if the collection that we have is not enough, we all have to safeguard it. So that's why we all have to watch out for whatever you're contributing. Even if it's branded 2.75%, it's all one common pool. Even that tax of 4 billion allocation, it is still our money that is just being put there in small portions. So what we want is our money to be safeguarded, to do what it's supposed to do so that we can benefit, because the state has a duty to provide healthcare as a social good to the people. That must be there. That's why the president is struggling with how do I do it. But the persons designing the systems, they all have different ideas, and if they're not working, that's why you're having all these conflicts between the people and the expectation from the government.
Remember to follow us live on our Facebook platforms, YouTube and also TikTok. We are at New Day TV, and today we are talking about the shift from NHIF to SHIF. Send in your comments, your questions, and we will be looking at that as we proceed with the show this morning. Maybe Maroah can ask a question. How do you think SHIF will affect the delivery of primary health care, especially where the clinical officers play a very vital role when it comes to giving services?
A good one.
Yes.
But before I respond, I wanted to take what Dr. was talking about.
Okay, you can start with that and then answer my question.
About how money is stolen. For instance, when these people are stealing, and if they have involved a patient, I got one of the case and I reported this case here in Nairobi. And actually it was involving a journalist. The wife had slipped over and had some injury on the leg. Then when they went there, they had indicated to have done operation. And there was an operation that had been done. They had claimed 280,000. So when the message went to the patient, then the guy was like, what is this? We didn't do any surgery. So he called me because he had my number. Then I said, okay, we can take action. Well, now we followed up this matter. When they went, they called the lady and they offered to give her 50,000 so that you don't say
50 or 15?
50,000.
50,000.
Yes, because that the money claimed was 270,000. So there is a way, even they have been collaborating with the patient. Patient knows that maybe I don't have anything. They look at you have never done anything. They come for the patient. Patient is told, you will say that you have been done 1, 2, 3. So if you are asked, this is what you do. So this is what we want to kill. That we have very strict action that can be taken against anyone who have been found guilty. Because then even this case was reported to NHF. NHF never did anything. The facility continued to operate. It is still receiving funding from NHF. Why? So if we can be able to have a system, a very strict system that if it is Gibore who have been found culpable of engaging in a scrubber's business, stealing from public fund, I should not be ever given an opportunity to continue serving. First, I should be out, and then I should actually be held responsible for my action. Then any other person following the same should know that that is something that I should not encourage.
And what happens
including the patient
to the institutions that actually contribute to this kind of scenario?
Yeah, nothing has been happening because you remember last year how many claims were raised and there was
and there was a
close to
crackdown
7 billion that had been lost, involving around 3 facilities in Meru. Up to date, the facility continued to operate. And I remember we had reviewed and tweaked the act to look at what we call membership empanelment, that is service providers empanelment, and we also have what we call facility empanelment, so that then you hold the individual responsible and also that hospital and responsible for the action that is happening. If it is happening within the civic of this hospital, then I have to take responsible as the manager of that hospital. So, but that has never been implemented. So the implementation in terms of safeguarding the resources that is intended to service delivery has not been has not been acted upon. As you're talking about now service delivery in terms of, you are asking about benefit.
No, I'm asking about how this will affect the service delivery, especially for the primary health care, considering you people as the clinical officers. Yeah.
I'm an advocate of primary health care because the surveys, research have been done, and it demonstrates that every shilling you use in primary health care, that's preventive services, you prevent, you save 9 shillings that will have been used in curative service. For instance, I come from Nyanza. If you can prevent malaria, you will actually, you'll have actually saved several cash, or rather millions, that will be used for treatment, because you find that once you have severe malaria, you must be admitted for service, and at what level you're being admitted, you'll be admitted at level 4 and above, probably, costing you a lot of money. So, indeed, we feel that if the government can go full-fledged and implement the promises under the primary health care, we have now the people we call community health promoters. The community health promoters are not health professionals. In any case, what they do, they bridge between the professional and the household, which in the same act identify the household as the primary unit for service delivery. So then they are the people to move around and mobilize people and sensitize people about their conditions and about protection, on how to ensure that they protect, and ensure that if there is anyone who is sick or found to have shown an indication that they are sick, they are processed and forwarded for treatment, so that you don't wait until complications sets in for you to get medication. So what we are saying is that if government can now make it real and put the money where it's supposed to be used, because then that's the only way we can realize this. Now, I'm worried when I look at what we call the benefit regulations, which have been provided. Those benefits, if you look at the primary health care concept, and now the benefits that have been designed, I feel there's a lot of gap, because already they have put a lot of caps and limitation to the extent that probably limit the services that is supposed to be realized under the the primary health care. So to that, then it's more of a status quo, rather than actually encouraging the opening and accessing.
Could you maybe expound on that?
Let me expand. That, like for instance, when we talk about primary health care, we talk about preventive, promoting life, and preventing infections. When you prevent the infection, doesn't mean that indeed you may not get sick. You may get sick, but we will pick it at the earliest stage for any intervention to happen, so that then you don't complicate. And when there is an earlier diagnosis, for instance, I give a good example, for instance, for non-communicable conditions like cancer, even cancer or diabetics, management is easy. Now, I come from Nyanza also. Sickle cells is a condition that affects very many people from our area. Now, we are encouraging that we can actually start what we call early screening for children, so that then we are able to pick that condition early, before we wait until a late stage when it comes with a crisis. And then you find that you are being hospitalized without any information, without even having learned about it early. So then you will actually plan for it, because it is already in. It's a sickle cell. You are not it is not something that you treat and it gets off. You'll stay with it, but you'll have known and planned for it. You understand? Now, I want to expand on what you are saying. That tell me, there's something I was saying that yes. That when now which good example can I give you? So then when now you don't do that, at the end of the day, is that you have gone back to where we were under SHA, that your primary health care, you are going to seek your condition, you are being processed to Kifika hospitali, you're already very sick, you are going
Very
to
sick
the admission. So we will avoid an admission at the end of the day. Now, this thing calls the regulation that they have brought, there is no like school program where we have to educate our people. There is no public engagement. They have not costed that. So if I have today to do public barasa and educate them about the importance of having, or rather, what we call managing their waste properly, I don't have any package. They can't pay me. So what I'll do, I will stay in the hospital and wait for them to be sick and come. Instead of going to the hospital, to the maybe schools and do deworming and teach the children
how to
proper
prevent,
information on how to prevent themselves, using mosquito net to prevent these conditions, I will not go because you have not costed. So that is what I was calling that this is more of a status quo. Now, like screening, if you look at what they have done for non-communicable conditions, they have not costed in terms of how should I be able to do the screening, and if there is any tests that are supposed to be done, they have limited the kind of tests you can do for those patients in terms of chronic conditions. So once you have not costed, that's to mean you will not pay. So if you don't pay, I'll not do it. So if I don't do it,
they
it
actually
will wait until the late
the
stage.
cancer patient covers up to 400,000 for various oncology services. I think level 4, 5, and 6.
So that's what we are talking about. Primary health is level 2, level 3. So at level 2 and the level 3, this is where we ought to be doing the screening, early screening. So if you empower those facilities to do it at that early stage, because most people wait until when I'm complaining. That's when I come to the hospital. So if you have to wait for cancer to start complaining, that will be at what stage?
Of course, it's
stage 3 and
chronic,
above. Yes. So like for cervical cancer, breast cancer, this need to be done early. And you have to pick it early. If you have not given any incentive for the officers under those law facilities to do it, they will not do it.
They will not do it. There's a question for you here, Wakili. What are your views on the proposed reimbursement rates for medical procedures under SHIF? Are they very adequate to ensure that healthcare providers can maintain high standards of care?
Well, that question can have two answers.
Okay, first answer.
Well, the first answer, if the services are going to be accessed at public facilities, normally because of the way the government pays salaries to the workers, it pays maintenance, it buys drugs, costs at the public facilities are already subsidized. So it's not foreseeable that the cost will be that expensive at public facilities. And we all know consultation is 50 shillings at the district hospitals, 200 shillings, maybe at level 4. The only ones that are quite costly is like level 6 is Kenyatta, DRH, Kisumu, whereby they're charging about 600 and above as consultation fees. So majority of the public facilities cost is somehow manageable. So to this facility, in my opinion, the SHA packages, the way they've been designed, they can be accessed without causing distress to the big funds, and they can sustain the program for quite some time. Now, on the other side, now the answer to the public sector, because you see, healthcare is complemented, it's provided in different ways, publicly and privately. The private system complements what is not available on the health side. Now, the cost of care on the private system, it's quite high, because now everyone is paying salaries, rents, utilities, drugs, everyone is procuring them privately. And bringing this as a cost factor inputs and sells it to the patient. When you sell out to the patient, the cost goes too high. Now, the cost of reimbursement is not inadequate as per the SHA package. Now, depending on which system you're serving in, the persons in the private sector will feel distressed. They will not feel like they want to onboard on that. And if they have to onboard, they have now to look at ways to cost cut. Either get, I don't know what stuff, because salaries have to be paid. And staff salaries make the biggest chunk of the operational cost of a private sector unit. Because you have to pay a doctor. Different types of doctor for different things. On regular, because you're supposed to be a full house unit. You have to stock up drugs and drugs that are working. Otherwise, you stock up funny drugs, patients also not get cured. You also have to maintain standards, cleanliness and all that utilities. You have to bring them up. So it's not foreseeable in my own assessment that private persons will feel like they're being shortchanged. Yes, they'll want, but I feel like it's a little bit tricky. Now, the other arrangement is whereby you're now having prepayment. You're being told you have like 1,000 patients who've selected your facility.
Yes.
And we project how many times these persons are supposed to visit your facilities. We say like they probably will come 6 times in a year. And the family of that person is about 4 persons. So you project the number of instances these persons can visit. And then based on previous data, you also project how much you're likely to spend on them. And then previous years by NHI, they were projecting 100 shillings per month.
Yeah.
And they were paying about, I think, 1,200. I don't know, the competition about 1,200 in a year. And then that's about 300 bob per quarter. So if you've selected 1,000 household or persons in that area, you're paid that money as a quarterly allocation for you as the owner of a private facility to go and buy drugs, to pay salaries, and just plan yourself so that you can be in business and be waiting for these persons to come. So when patients come and costs are probably too high, now some providers, see, the law was changed in 2019. This is a different law, the one that regulates facilities. You have business persons who are running facilities. The ethics of how a doctor is trained or a clinician is trained to run a facility, we're also interconnected. We don't want to do harm to the system or to the patient. But business persons' interest is the bottom line.
Yeah.
So they'll do a lot of magic
to
just game the system. You fix persons in the facility, you bring in fake people, then now you will be paid in advance the capitation amount at the beginning of the quarter. Then you wait for a patient. Now when the patients come, you probably start not doing the right thing. Just hear them as they come, they sit, you listen to them, you draw blood from them, you probably don't do the tests because the reagents and the machines are too costly. So you end up not doing the tests. And then at the other end, you have someone who's selling drugs just because they have to sell something to you. So you're in a business of just pushing things and moving items because money has to be made.
Yeah.
So when you fuse business interest and professional interest and ethics and you don't have enough regulation, a lot of chaos operates there. So it is doable, but we just have to change how we do things. In the
I think we need to demystify the commercialization of the health services.
Okay. A lot of games.
When he talks about that, I think I normally ask myself, like, what has been happening currently? If you were to do a cesarean section in Mama Lucy, it will cost you around 15,000 under NHF. If you come to KNH, it will cost you around 115,000. If you go to Nairobi Hospital, it will cost you 260,000.
Yeah.
Unfortunately, Kenyatta has more resident consultant obstetrician who are probably the one crossing over to do the same surgery at Nairobi Hospital. So then you wonder what changed from Mama Lucy to KNH to Nairobi Hospital. So we have encouraged that system of jumping to the higher side because you think that probably the service which is being offered at Mama Lucy is not up to standards. Yeah. So then I go to where money, the NHF can get a lot of money. Why should NHF pay 200 plus like Mater Hospital and the biggest referral hospital like KNH you pay 100? It doesn't go well. So standardization is good. So that then, for me, I feel if you have to pay 200, then the highest facility should be getting that money and all the facility under it. And how do you rate that? Is by virtue of the services that we are able to offer. How many consultants do you have in every department? So then that informs the readiness for you to offer those services. So I concentrate to empower you more. A facility that rely on another facility anymore, that is what I call commercialization, because then you find that the individual who are making decisions, they have a way they benefit from those private facilities. And that's what must be killed. Standardize. If you have to onboard our members, this is what we are paying for. And do not ask extra money from this patient. Indeed, quick gain or quick money that people want to get from NHF, that's what killed the NHF. Because then I will be asking, if it is a certain procedure that I'm doing a laparoscopy, does it change? Does the instrument change? Does the individual change? It's not. So why should it that by virtue of the name of a hospital, then that one changes? So for me, I feel that need to be looked into, and I really support standardization of the payment, so that then services, all facility can appreciate that services, and I'll improve even what I pay for Mama Lucy, so that I pay them 50,000 or even higher, so that then they can improve their services and have more staff that they need. They need for them to offer services.
Okay. I could include on that. You see, the journey that you're traveling on has been traveled by other countries, and we can borrow from them. So our principle for now, we say it's social health insurance. The president, because he has to sell an agenda, he says it's free for all.
Is it really free for all? It is not.
To distinguish, because he needs to be guarded with his pronouncements. Because if you overpromise, and the system itself has its own complexities.
Before you go promise, maybe demystify the issue of free services. There is nothing called free services.
Yeah.
You have already been taxed. It is your money that is being used to procure your services. So services must be paid for at any means. So there is no free services. That's a very wrong language that normally people use, that there is free services. Free may be meaning that when I'm going to the services, I do not pay over the counter, but at the end of the day, the services will have to be paid for.
Yeah, because they were gotten from your taxes.
Yes. So, but you have already been taxed. So someone is holding your money in trust. He will pay for the services that you are.
It's like the way you're saying you will use roads for free, or you use the public lights for free. Of course, you paid for it. Other people have paid for it. We all collectively paid for it. Now, like I was saying, the journey that we've traveled has been traveled by other countries.
Yes.
Okay.
Right now, it's being sold as a free form of financing. There are other aspects of payment in different styles. So for now, it's full pay. Pay and go home, no one will ask you anything. But there are other models whereby you can have someone paying, the government or the system paying for you some amount. You top up the difference. There are other places whereby if the difference has not reached a particular level, you will the one be liable to pay anything below that. But when it reaches a particular threshold, the government or the system will pay for you. The other one now you co-insure, you pay 50-50 or different percentages. And the other one now you pay a small fee, like a gatekeeping fee, which is known as a copay. Before you get into the facility, you ask, like, bring 200 shillings or bring 500 shillings. So all these different models have not been, maybe they will be deployed, because it's a journey of insurance coverage. It has to be traveled. And once you get a particular arrangement of how the operations run, that's when you'll have the model working for you. So there is something that Kenyans we like. We like the best in everything. So you go to a public facility. If you don't get what you want, you will complain. And the cost of that thing that is good is costly elsewhere. So now trying to manage choice, you're free to choose where to go. And if you're locked to a facility that is not offering you services, we will complain, because it's our rights as patients to choose where to go. So the right of choice is not limited. And being limited means you'll not get the best of services that is supposed to bring you the quality of health that you should get. So my proposal would be, in this aspect, for patients to choose and be given a choice. And if the choice is expensive, and you are aware about the cost of that, and that's the reality of things, you be allowed a choice to do a top-up or a co-insurance, or do the other form of deductible, so that it balances out. Otherwise, premising it's free, and then you give choice, you will go to Kenyatta Hospital, things will be expensive, and the system will not work, and then start feeling frustrated. And that now will mean the system will not start working. It will be like the way we had NHIF. You see, the years between 1998 to around 2012, the struggles that NHIF had of acceptance, of persons just saying that's just a card for the bed. No one wanted to onboard on it. It was still mandatory for employers. And around 2015, the new constitution, there's a lot of marketing and rebranding, and NHIF somehow picked up and even brought in more members, because they realized that patients really wanted healthcare to be covered by the government. And it did work. So that journey of 1998 to 2012, it's many years. So you can imagine now traveling the same journey now with another authority for many years. So there are things you could have learned and improved and deploy out. So I think we still have time.
We still have time.
I keep saying that.
Maybe I would also want to pick your mind and hear your thoughts about the MOH releasing the new tariffs to the benefit package in the new Social Health Insurance Act medical scheme. Maybe you can just
that's
comment
a process,
on that.
That's a process that began this year around February. They met, they did a few costings of the models, they picked the numbers of attendance at the public facilities and tried to model out the instances and the cost of inputs at the public facilities, and now they modeled how much a package should be. And they tried to cover at least most of the areas. And at that beginning time, most of the areas were covered, but now where we are on the instances that they've tried to undertake the process, they've left out some or reduced the number of limits or the instances that you get to have a particular benefit. Like in this case, the one I keep referring about is the dentistry package. The dentistry package has been totally left out, and they're saying they'll wait and watch to onboard it later. But at the start, it's not listed there. And the practitioners in the dental field, even the patients themselves, feel like our sector has not been catered for, and they are protesting about it, and it has to be included to cover some of the basics. For the ophthalmology and the eye benefits, they're there, they're listed. Now the cost of the glasses, I think it has been reduced, and the number of instances, what can be done, you can visit a doctor in this particular case has been reduced as well. So they're trying to balance out. The reason why they're balancing all this out is because there is a yield, there is a cost of running the operations and the number of patients you're likely to see, so that you project how much money you need. So these are projections that was shared in the supplementary bill or the finance bill, but the appropriations bill, but they're the ones that were now reduced, and they feel like the fund is not going to be sustainable at the instance. Because if you have less persons registering, less persons contributing, and government bringing in less, and you over-promising on the other end, that's recipe for chaos. Because after those first 6 months, first 9 months, first year, 2 year, and the math is not working out, because you cannot beat up people to bring in contributions. It becomes a little bit tricky. So the tariffs have been done. And in my view, again, they'll suffer the same challenge. Public participation has not been adequately done. It's been done in a few places, and even as we speak, the public is still not aware about what tariffs. So it has been launched, it's been in the press. I think the publication is likely to come out, and the gazettement is coming out soon. And be like, okay, this is what NHIF says, and this is how much I contribute. So if there's incongruence in that information, and then acceptance becomes an issue. It becomes like even NHIF was offering better than SHA.
And SHA.
When patients get that kind of an idea, in legal engineering, nothing is impossible. I keep saying the ship has sailed, and we cannot go back. In law, nothing is undoable. Everything can be done, and we're all here in this country, and all we want is systems to work in the favor of what we pay for. Because 55% as tax for the employed and the non-employed, it's a lot of pay, and you should get something working from your government.
The SHIF, the SHA, both have their good and their bad. We're looking at the Linda Mama program, which has actually been incorporated into the SHIF, and it is supposed to actually try and enhance the gains of and reduce mortality or maternal mortality rate in Kenya. Your thoughts about that? Because initially it wasn't there.
I think Linda Mama came in after realizing indeed that we needed to ensure that we guarantee accessibility for services by the expectant mothers, and also after, during delivery and after delivery. It had its limitation, and we believe then what the SHA intend to do is to approach the whole issue in a wholesome way, without waiting until then when you are pregnant for you to get the services. You continue getting your services, and your services continue even after delivery without limitation. For those enrolled under Linda Mama, even previously when they were enrolled, after delivery, they used to take care of the mother without a child. Then there was issues which were raised. They adjusted at least to take care of the child within the first 14 days. And we find that when complications sets in again, they go back to their pocket to contribute and ensure that services are delivered. So it had its limitation. And today I can say without any fear that indeed when you look at what SHA is projecting, if it was to be implemented, as the Dr. continued talking about, the challenge remains the money. Because again, when you talk about the funds that are supposed to guarantee the services there, that is not there. Because the minimum projection that had been done was 15 billion. It's not that 50 billion is the one that we intend to be. We need more than 50 billion. But we are saying, let's start with the 50 billion. But when you give 4 billion out of the 50 billion, you have actually more of state that implementation of that for that services. So to that's why people will have more fear that indeed they may lack such as critical services whenever they need it, and they are justified. And this question does not undermine by any way the SHA, or rather the goodies that SHA is promising. We are only saying we need to be cautious because life has no second option. Once you are sick, you need services, and you need services. You need services without waiting. So there is no time in terms of waiting for you to get the services. So we need to say that yes, it has played its role, but it needed to be taken to a different stage where the integrated services can be encouraged in terms of everyone getting the services whenever they need them. Because, and you see, I think probably also the legal people need to advise the ministry properly. When we talk about government providing fund under primary health care, that everyone will get services for free. That's the statement as the doctor has insisted. It only means that you have no reason for me to be denied services at that level. But they go and more of make it without any written law. They say you must have been a paid up member or have been registered. That is a cosmetic statement. It is not based on any law. Yes. Actually, people will claim services at primary level facility, provided they are registered, even if they are not paid up, because then you have already said you are using public resources. So public resources that you are giving is not relying on my contribution. So I should be able to access that services at that level. Yeah.
Maybe just to talk about the contribution, the income-based contribution system that has been proposed under SHIF. What are your views about the same?
Again, they're doing out the two models. For the persons who are employed, it's a gross pay rate taxation.
Yes.
Just like pay with the name of it's a tax towards SHA. So it is 2.75% of the gross salary. So everything that you as an employed person take home, you get in 2.7% deducted towards the particular fund. It's like an earmark of the fund, of the contributions towards the big fund. Now for the other persons who are not employed, it becomes difficult. Previously, there was a voluntary aspect of contributions in the NHIF. Now they suggest that they will do a means testing. It's like an econometric test to check what kind of contribution would be fair for you based on your circumstances of living and what you do. And from that tool, so the tool is subjective. So it's like a form you self-fill, and then there's probably someone on the back end who checks and assesses whatever you've stated is true. And they probably have to send persons on the field to even check you whether whatever you've done is truthful. Now, if they assess you and they see like you have a TV, you have a car, you are understated, you're claiming you're not employed, but you have all these benefits, you should contribute this much. So you probably have a figure attributed to you per month. Now, the condition was for those persons, they're supposed to pay in advance. For the persons who don't have regular sources of income, they're supposed to prepay in advance and a full fee for the full year.
For the full year.
The law was even, the judge was even a little bit skeptical on how that would work, because you're asking persons, the employed ones pay regularly at their pace, because every 30 days you pay. Yeah. You who's unemployed, someone tells you upfront, you pay 600 shillings probably per month for a year, that's 7,200, and you pay that in January. Failure to which, you're on your own.
Do you feel that kind of system is fair? Actually, for those who are not
it becomes
employed.
a bit tricky. So we have to rethink whether we'd want to work with that model or just try to have these persons on this system who are not employed contribute towards the fund in a different form of taxation.
What are the potential challenges?
Different countries have done different things. Even have had mobile phone taxes, like an extra excise duty for everyone who's having a phone. That means the person who don't have phones will not probably pay that tax. like an airtime tax towards it, like a transport, something on fuel. And you can also have it either on sugar, you can have it on unga, like an extra percentage that is somehow equitable and distributable across all the persons in a way that it is not regressive, so that it takes too much from the poor people, but it balances out contribution in a way that everyone feels they're contributing towards it. So, like in the UK, their taxing system is you pay. And the government sits and look at the full pot of pay and allocates. This is now what's going to go to healthcare. The way we have allocations from the roads. So you got 4 billion for PHC. You had more billions allocated towards roads and towards other programs. So if you are keen that this is a project you want to run and you're taking it up as a government, allocate enough funds. So contributions for now, as they look like, they're not equitably laid out, planned out. It looks clear for the employed, but for the unemployed, they'll be the latecomers to the game because everyone will come on boarding at their own pace. So they'll be the ones, again, the ones mostly affected by these conditions because they don't have an income. So whenever catastrophes, medical emergencies face them, they will not get it. Again, back to it, away from the contributions thing. When the Constitution came in, right to emergency care was free. But since 2010, we have never operationalized that benefit. Again, in 2017, it was put up in the Health Act that there will be a fund somewhere, either under the Treasury, to bring out the benefits of emergency care. Now, this again were never rolled out. And now it's this time around that we're saying, we can place this emergency care under the SHA, put it under the Emergency and Chronic Illnesses Fund. And it's supposed to be a pure fund paid in by taxes. Well, it's well and good. And if the allocations are not adequate, again, we're going to have issues there.
I asked a question, what are the potential challenges for this kind of a system contribution?
Well, the way it is, it looks unbalanced. Because the persons who are paying freely and others feel like the whip on them is too stiff and they feel like we are being exploited, or we don't have that money to pay. If you can have the same model of paying in the same monthly installments like the others, then it becomes a little bit fairer. If the tools of econometric testing tools are well designed and they're able to pick out, then they can work. You can even see what has happened in the education sector on how to pay school fees. There is a tool that you fill up so that it assesses how much you're supposed to pay as school fees. So it's the same kind of tools that you'll use to check what will you pay. So these challenges of persons not understanding the tools will be there. Because right now it's a self-assessment tool on the website. And probably you'll have persons going on the ground, either the CHVs or the CHPs, moving in to check where you are. So if there's information incongruence, again, that onboarding these persons become a little bit challenging. So contributions from the indigent pool will be slow to come for now.
Okay, especially for those in the informal sector. Maybe I would want to get your concerns or maybe your views about the affordability of that, especially for people with very low income.
Let me say, I think the question is what are the challenges that are likely to get in terms of collecting these funds. The first one will be what we have been experiencing, even the current one, is that we have difficulties in terms of payment. Like today, many people who are working in the county are deducted money. For instance, I can give a good example of Marsabit. They have been deducting money for close to over 7 months without remitting the money to NHF. So meaning these people do not access services. They have been already, their money has already been deducted, but it has not been remitted to the NHF. So meaning they can't access any services. And that is a problem and a disease that's affecting many entities in government and private sectors. So they deduct money, they don't remit, they don't not know that indeed your services may be denied. Now they are saying under the same act that the money the county government and the employers shall deduct and remit money on 9th of every month. They say that of every month. They do not say of the preceding month. So it will still have some challenges because even previously that's what it's supposed to be. I take it back. Payment for salary is supposed to be on 5th of the subsequent month. For instance, this month my salary is supposed to be paid on 5th of next month.
Yes. Not
later than that. We have experienced where people goes for 3-4 months without pay under the counties. So what does that mean? It will affect service delivery because even when deduction has not been done. But again, even Treasury has been delaying the money that's supposed to go to the county, meaning that the counties are not able to do anything. So when government says that for a person who is not employed to pay aptly every new year, you pay, the list will be paying 300, meaning that will be 3,600.
Yes.
So 3,600 at that beginning of the year, I'm considering taking my child to school. I'm struggling even to put food on the table. And you tell me to get 3,600 from where? And you say I must pay it within that time.
Yes.
Government itself cannot pay that money to counties aptly.
Yes.
It cannot pay, because then it doesn't mean that the billions that counties are supposed to receive, then it's too big. It is about, actually that percentage, if you correlate it, that money is too big. 3,600 is too big for that patient, or rather who is a farmer somewhere, and probably that year they have not harvested anything. You are either forcing them to sell the same cow that they have to milk and give some food to their children. So I think that must be thought very carefully. The mean testing, the mean test tool is something that has not been collaborated very well today. To our own system. You know, people are sitting in the boardroom and they come up with something they think that suits everyone.
Yes.
It is different. You know, if I was the one to advise, I will be bringing back the system where the chiefs were working very well, that the system can be able to help the system to function, so that they are able to inform, they know very well. But again, with the kind of corruption that we have, that you have chiefs that can even process people, and by virtue of being my family or relative, you put them in a certain level so that they are able to benefit from that, or they reduce the cost that they are supposed to be spending. So even the mean test, testing tool is a subject to the people who operate it, is a subject to the administration, is a subject to everyone who is feeding it to ensure that it gives them a certain position. And it's going to face the same challenges that we are seeing with the funding at the education level. So that is a big problem for me, that collection of this fund might not be as they have been expecting. Looking at only the registration, even those who are already under NHF, they are slow to transition to SHA. Similarly, it will be difficult for every person compliances in terms of this law. And to that, then it poses a big challenge in terms of service delivery, because then you need to get that fund for you to plan for it, to ensure that you know what services to give at what level. Yeah.
I had asked a question about the informal sector, especially your concerns about the people who have actually a low income, the affordability of this.
Yeah, I think that's what I was saying. Let me go back again. The informal sector, probably a carpenter and someone, people who are self-employed, mama mboga. These are people who live, majority of them. There are people who probably are doing business. They have been able to invest. They have a mama mboga, but I have employed several of them who are selling on my behalf. So they get at least some money. But the person who is seated there selling that mboga probably takes home 100 shillings every day. So 100 shillings means they have to buy unga and they have to buy some few things so that they come back again with only 10 shillings that may enable them to reach where they are supposed to be working. So they will be experiencing difficulties because seasons dictate what they get, and some seasons are very harsh to them. So thinking that it is a uniform way is a very difficult thing, and government must be real. It's not that they don't know. They only postulate and rather thinks that things will happen the way they are thinking. But in reality, when you go now to functionalize this, you realize that it will be very difficult for you to do it. First, we want to see the government to ensure that, let them identify, because government has money. Let them identify the indigents first and say, we have already paid the indigents money. So then we are influenced for us also to continue supporting the government in what they are doing. But if theirs must lag behind, and you have to push the peasant farmer, or rather the poor people, to ensure that they're the one to set the ball rolling before you do it, I think it gives us a lot of challenges. Like for instance, currently we know that it's not that the government doesn't know. They already know the number of people, poor people who can be supported from Turkana, They already know the number of poor people from Migori who can be supported under the Ministry of Labor and Social Protection. They already embodied several people who have been receiving those benefits, including the old people. So let them start from there, that we already have a certain database that we want to go and collaborate. And this is the problem we have. Like now the budget that they have 4 billion for primary healthcare, 10 billion for administrative services and coordination.
Yeah.
10 billion for why? For me, it doesn't speak really that you know what you want to achieve. Why should you allocate 10 billion? What is that percentage to 4 billion? I will have chosen to put 10 billion at the primary healthcare services and now change the 4 billion to be administrative cost, so that you cut down the cost. One of the cry we had with the NHF is the high costs and the untamed costs, which administrative costs, and yet services, people are not appreciating the services. So until indeed we embrace and categorically choose to embrace people with the service, we'll still have difficulties with implementing the SHA. Yeah.
I have heard the chairman for SHA saying that they have the NHIF employees who are supposed to be helping with the transition, but they'll not actually be employed. They will be let go so that they can advertise for the jobs and get new people to work for them. What are your thoughts about that?
Well, see, NHIF has been, we have all been here.
Yes.
In the case of so many things. And the spirit of SHA was drop everything and start anew. So drop everything and start anew. Okay. You're starting anew with the same mindsets, people who are affected by the same culture. So the same game will still likely move in there. So that spirit of drop everything, start anew is, it's a replica, but in another name. But the cost factor. Now away from that, it's not okay from a labor point of view on transition or mergers or acquisition of different kinds of entities.
Yeah.
Ideally, you're supposed to translocate with your people. But maybe they say the culture, organizational culture that was at NHIF is not what they would want. They'd say, let's subject these people to a further vetting. Like the way we transited from the old constitution to the new constitution, and judges had to be vetted anew.
Yes.
And some were asked and others were
proceeded. Yeah.
So they say now we vet the managers, we vet the quality assurance people, we vet every staff at NHIF. They reapply for their jobs, and if they found fit, they'll be taken in. If you put another factor of if you had beef with someone as you transist, they will probably be left out. So that becomes an issue of now redundancy, whereby the law allows for redundancy payments for persons who have served. So that will be the route to be taken, that the entity has folded and you'll be paid out your dues and you take in. And if you're taken in, you're renewed on a new contract term and you continue. So there are different aspects. There is the other emotional aspect of why did you leave us? So the why did you leave us, the emotional aspect, it's a little bit not clear because the law provides for both instances.
Yes.
But ideally, if it was reforms, you just check whether it's human errors that are causing all these issues and fix them. If it's operational issues that are causing issues, you fix this. Management issues, fix them. Financing issues, fix them. So the different entities that affect service delivery. So all these areas have to be checked. If they're not well checked, you'll just end up with the same game with a different name, with the same problems, and a very expensive budget to promote this agenda. Because now the cost of promoting SHA, like he talks about, it's too high.
It's too high.
And as long as acceptance is low, you'll spend more, you'll print more t-shirts, you'll do more road shows, you'll do more radio TV shows, adverts. This is good money, contributions that could have been going to treat people. But now because we're in business and printing t-shirts and winning tenders to print t-shirts is the in thing.
What are your alternatives? What are your alternatives to SHIF that you would propose as a union to help achieve universal health care? Yes.
Well, the alternative would be like to rework the model. Okay. First thing is to check, do we go for the earmarks the way we are working with, or just say this from today, the cost of taxation will not be 30%, be 31 or 32 for those persons, and we'll add maybe another VAT or maybe 31% and a VAT maybe to 7%, or introduce a different kind of a levy elsewhere and earmark that tax to be effective so that tax can be contributed by everyone. And then project how much. The way we projected the road maintenance levy, how much you're likely to collect by the number of cars, by the number of petrol stations you have, the amount of fuel that's bought. You're able to project how much you're likely to collect in a particular period. Then with that fund, plan out your services. Then check out the threshold of usage of the services. And provide, there was a time NHIF attempted to say that you'll be allowed to visit a hospital 4 times.
Yeah.
You'll not be allowed to go this number of times. So try and cap those numbers of how much limit you can get. For the sustainability part in the first instance. Then as you grow and as you collect more, you increase the thresholds and the limits now. And then you bring people on board that we want this to work. And if it's not working at the first instance, it's because we're having these challenges. But give us time as we're moving on to try and pop up more so that we can give you more. And it would work. So it's a complex journey. It's not easy. And very few countries in the whole world have actually succeeded in this. Very few. Others succeeded for a few years and then they started dipping. Because the funds were not projected in a way that was sustainable. So the cost of consumption for the system becomes too high. Because if you're assured of healthcare, every day if you have you probably feel like today you're bored. And because you're bored, you feel that is an illness, you go attend to the doctor. And you'll be charged. So those kind of gatekeepings have to be introduced to check spend that is not supposed to just be there. Because some patients just visit hospitals, especially when they know they're not going to pay. So you have to gatekeep and control that cost of spend. Okay. So to balance those things, it's a never-learning journey. Now we are starting anew. That means the journey is too steep. So we hope that you have enough of persons to try and work out the math.
Let me say what you asked is that we don't know. We already shifted because the CEO for NHF is the CEO for SHA. So in any case, they already amalgamated at a certain time for more than a year now. And I don't know whether even Engineer Kamo is still the chair.
They're still there.
He was muted. You see, any question about NHF, it is answered by the chair for SHA.
Yes.
And that's mean already they muted the other side. So looking at it is that already they have chosen people who they want to be on this side. Okay. This will just be an exercise that already it is. You can actually look at how they are designing it. They already know who they want to transition. They know who they want to layer. They have given 3 options. Okay. People can choose to go home and take, they leave services and they be paid their dues and go. And the other people can choose to remain. And if the SHA does not want to have them, they can lay them over to other government institutions or other ministries. Or you can, now you will apply for the job. If you are successful, you can be enrolled under this. This is a process. We know how employment happened in this country. Already you'll see an advert, for instance, from Migori for people to be employed as a clinical officer, but they are already in the system purporting to be doing some services. So when the advert is at the end of the day, those are the people that already. So we already know who is the CEO, was the CEO. So we already know that probably we have seen some people being fronted like directors in certain areas. They are already people who are fully incorporated. But we see there are people who are directors level at the NHF and they have never been involved with the SHA. So you understand that already. It is more of you are exiting. So we can still say, when you see it working like a duck, you can't call it a different name. It should not. It must be a duck.
It must be a duck.
So the expenditures that you're talking about, for me, I look at it and say, in this country, we have never lacked any good policy. We have never lacked any good laws. We have all good laws in place, starting from our roads, how we need to behave on our roads. But do we behave as such? No. So implementation is a big issue. And we believe that as the projection goes and the question that we raise is, once you start assuming like the question people are asking do not matter, then you lose it all because then people must own the process. They must own the services that you want to offer them so that they feel working with it. Now, if people complain about a certain process, you report a certain incident of theft and they don't take action, I'll not report the next one. Yeah. So we need to see a system that is encouraging positive input and discouraging negative attitudes or other behavior. So then we'll see that people will start associating with it. where we are as a country, I think we can call ourselves a very active, involving country where everyone wants to get to know what is it that you want to do it for me, why should you do it for me, why haven't you involved me? And the Constitution has given us that right. So as he has said, we have the legal limbo ahead of us. We might see the court throwing us to the drawing board, or the court might give us a limelight to go. So then, for those who have been probably lagging behind, you'll start now chasing the government as they run, thinking they have won. They will not win until they're working with everyone. Yes.
There's a question here for you, Maroah. They're asking, Mwangi is asking, how has your union been involved in the planning and implementation of SHIFT? Do you feel like the process has been inclusive and collaborative?
Yes and no. Okay. Yes, that at least I admit that indeed I participated in the designing of the Kenya Kwanza Manifesto, and I know the issues that we were projecting there. I was the proponent, and if you see the Kenya Kwanza Manifesto, the primary healthcare concept, I'm the one who designed that. And I feel that then I was purely speaking about the lack of proper structure to fund the system and the primary healthcare.
Yes.
So when this come in, that it come to speak to that situation. But thereafter, when now you have a government and people have been brought in who probably was not the dream bearers, they come with different understanding, and they want to do it differently. They choose who they want to work with. So the government has already people in place who they are working with. And for instance, currently we say, when the bills we were coming up with these bills, we raised specific issues, and we felt that they were not addressed as much as we were invited to participate. So then you query what amount to stakeholders' participation or their input to somewhat extent, because then you'll come and give your input. I think we have been participating in Dr. all the time. You give your views and you feel that your views were never considered. Yeah. So it's more of a cosmetic engagement. Of the recent past, I think, was it on Friday? They had
the KCC one.
Yes, there was at KCC trying to do verification. Was it verification?
Final rubber stamp.
A rubber stamp. And they went to read to people. I was not around, I was in Botswana, but you understand, they went and read whichever they have done. You have been called to be told what I have done and what I want to do. They were not telling people, because then, what is that verification? First, you need to share whichever you want to come and find. They never shared with people. So you are just invited to a meeting to do 1, 2, 3. So for me, I feel this is where the government always go wrong, thinking that they are different entity more away from the people. And we feel that, yes, as we appreciate that we have been invited to participate, we feel that our input have not been collaborated or rather been considered appropriately. Yes.
For you, there's another question. What future legal challenges could SHIFT face? And particularly as healthcare needs and economic conditions evolve, how can the legal framework be adapted to actually address this?
Well, there are future cases likely to come up on the basis that just like the last Court of Appeal judgment was of the Finance Bill 2023, Finance Act 2023, that if public participation is done, it must be done in a way that it makes people understand what it was all about. But it must not be just a face of an euphoria moment of we're having something new, it comes, just submit because you have submitted an email, and after that you focus on a different agenda and you say, I heard you, I told you to send, you sent, I read, and I did not like, you did not make sense to me what you said. And because of that, I've finalized the product, here it is, and that's alone now, the final instance. So that's why we're in court, the persons are in court because of that first instance of the laws, the 3 laws that were made. Now there'll be other case arguments again based on the regulations now, especially these tariffs and the fact that some benefits seem left out because the human body begins at the hair point to the toes, and there is now what the other aspect which is not known, which is the mental aspect which is happening. So there's mental benefits provided. But if you happen to leave out some of these benefits, like in this particular instance, I keep on stressing on it, dentistry has been left out. Reason being either the mouth exists as an external part of the body, which is not part of the body, and which has disease conditions that inhabit that area. So because of that bias from the persons designing the packages, they say they will not cost. They will not cost because they don't have data. or because they feel that the mouth is too expensive. I don't know whether it's the eye, the heart, the kidneys, because kidneys transplant has been factored, or it's mental conditions that are more expensive, or it's probably maternity conditions that are more expensive, or orthopedic procedures and fractures, or surgeries. So what's expensive, what's most important? And for you to make a decision that I'm going to leave out the right ear and use the nose and leave the mouth and leave the other hand, you have to justify why you're leaving things out. Because the human body has many conditions affecting it, and you have to cost care services around it, especially when you're paying enough money towards that particular fund. And again, with the presidential pronouncements of it's free, it's available, you can access it. Now, all these incongruencies will cause cases in the court. That means the tariffs are likely to be suspended in court anytime they are gazetted, because they don't make sense. And until they make sense and they assure persons of that right to health care that is in the Constitution, then it will become easier. So they say it's a progressive journey, that we don't have to onboard everything at once.
Yeah.
But then you're collecting everything at once. So if you're collecting and you're starting, the balance has to be there. Either we're starting with 1, 2, 3 for every part of the body, and the other things will come in later. Or if it's this much, do another model parallel to it, and supplement what you cannot cater for. And persons can now pay differently. So, but that's not the spirit of insurance, because insurance is supposed to cover for everything, just like it happens in the UK. There are struggles there, but they're trying to also balance out how it will work out for them. So it's a long journey, and it requires persons who are experienced in insurance, actuarial services, practitioners themselves, the challenges they're facing, and again trying to control the other factor, which is now the businessmen who come into the system because they know healthcare is profitable. They claim it is profitable. And once they learn a few things, they hire one clinician. They don't even meet the enough threshold of persons that should occupy a particular facility. And working with persons who are not qualified, all you're looking for is the profits. You're selling. There was an incident one time where I have a pharmaceutical company in India that was selling fake drugs. So those same things could still be happening here. So the world is not that small that incidences happening in different countries are not happening here. So those things must be controlled. Businessmen who are not really particularly interested in the business of healthcare, the way it's supposed to be done professionally and ethically, they need to be weeded out from the system, so that the system can be self-sustainable. It's a project that needs to work, because you're all affected in different ways. Now, there is another challenge that we're having, which no one wants to speak about, the fragmentation of the fund pool.
Okay.
You're having formally employed persons. Well, the law for now says you can supplement and purchase private insurance, because NHIF or SHA will not provide the best. So you'll pay 100,000 as premium per year to SHA, and you pay another 100,000 to, let's say, I don't know which one of the private insurance companies.
Yes.
And you'll have paid 200,000 because one is basic and it's mandatory, the other one is supplementary for these other things. And then the first charge is on the basic first, the SHA. Then the top-ups will be paid by the other companies. So now, persons employed in the civil service, they're having their monies deducted or contributed or paid out in those private bodies. Those are funds that could have gone into the SHA authority and be distributed to everyone so that everyone can enjoy the benefits in a way that it works. You've seen like 10 billion going to TSC, to TSC and then to TSC to another insurer. You've seen about, I think, I don't know, 7 billion going to the police, and then the police pays out that money to another private entity. Those monies that are distributed all over from the parastatals, from the entities, the government entities, these are money that can be pulled into this fund. And they have a bigger fund pool that works for everyone. But this over-fragmentation is not helping us in any way. We also have counties. Previously, in the previous government, you had Oparanyake, you had Keichik, Kitui, you had another one for who is this, the Kisumu governor. Every governor wanted to do a health insurance. So this fragmentation is not the spirit to pool funds. If the spirit is to pool funds, the way KRA collects, it collects. It distributes. It allocates. If it's, let's say this year we're going to allocate 120 billion towards healthcare. No one will pay. From level 1 to level 4, this is a referral chain. You cannot go to that level if you've not passed through the line. And these are the checks that you had. It's public money. So I don't even know why you'd have to bring in another private entity to gatekeep and watch your money. It's your money. You have the capacity. It's like hiring private police. to patrol the streets because you're not able to trust your policemen on the streets.
Yeah. It doesn't make sense.
So those kind of things are so smashed. It's a good thing, but with interests around.
So maybe I should ask, are you confident in the government actually implementing this shifting?
Well, the spirit is there.
Private
interests, they never want to be left behind.
They surpass.
They camouflage and come around and act friendly and propose ideas, and ideas are adopted into law, and it moves. So we realize later there are leakages and there are issues of inefficiencies. So those things will be discovered in the next few months when our claims are being processed. But we hope for the best because I don't want to pay like that much for health insurance. Well, the government ought to provide it. And if it works, that's what you want to use. The same way I don't have a private road to take me from Mombasa. I use Mombasa Road to take me to Mombasa. And it's been painful for persons who came before me. And we continue to pay for it. So that's the spirit.
Maroah, maybe I could pick your mind on the same. Are you confident that the government is able to manage SHIF effectively, considering what has happened with our NHIF in the past? Are you confident?
Yeah, I think my confidence always erodes when I feel like the input of the concerned is not taken into effect, because there's no way you can say you are total man, you understand everything until you collaborate everyone and allow that the beneficiaries and the service providers are appreciating what you're doing. So if that one is not happening, I will have a big question in terms of how long should we take to realize the benefits that people are really expecting. You know, like the cry we normally see. And I must be able to speak about what the CJ, the Chief Justice had talked about, the issues of having the MCS have money to pay school fees, the governors, and everyone wants to have a certain kitty. So then you wonder, why can't you put all this money together so that you offer free thing? So what he's talking about, I'm under Nairobi County. They know they, like a certain year, they used 280 million to procure private insurance, money that they pay aptly. They pay it once off to a certain insurance, and this insurance then purposed to give. And they do not meet the requirement for that, to offer that service. In the year 2019, when we had the COVID, we had challenged the government because under the Employment Act, it provides that it is the responsibility of the employer to guarantee medical cover. Actually, they call it sufficient medical cover for the employees. So that means that you must be able to ensure that all employees have a cover that can guarantee them services. So what they do, the SRC came up and gazetted the rates in terms of how you can be able to procure private entities to ensure that you procure services. Now, the unfortunate thing is also the law provides my mandatory subscription to NHF. So for us as employees, we say we already have a certain. It's not comprehensive. So what can you do? Please bring the money that you already allocating for the insurance, put it here, because me and my dependents are already embodied. So then you build it to make it a strong cover. But they choose because then they will want the kickbacks. They take it to private insurance because that's why they get kickback. First, they do not tender properly. They do not declare the principals and their dependents, and they do not declare benefits. So at the end of the day, a majority of people do not claim. So if you don't claim, what happened? After the end of that period, the money is gone. So it doesn't make any sense. But if our money was being brought to NHF, whether I claim it or not, the money remains in the kitty. And it will continue offering services for other Kenyans who need it. So that's where we normally differ with the current administration, and of course the proponent of the push of the SHA, talking about what they want to do better, and then they amass it with the other thinking that does not really meet the end, because they normally say the end mean the end means the yes. So when you talk about the services you want to offer for me, and the process is already entangled, I feel that we lose hope, and we do not have hope indeed that you are going to offer the services you're promising Kenya.
Your last take on this whole discussion.
The government has a duty, as per the constitution, to provide health care to the people. That's access to healthcare to the people. And access means many things. Access by proximity, by road or by transport, and availability of services by qualified persons. And again, access based on the fact that I need to pay for it, or I need to be paid for as a beneficiary of that system. So, and if it's a public good, which is healthcare, it needs to be readily available in a way that it satisfies my need as a Kenyan. So the government has embarked on a good project. The project has issues. It doesn't mean that the project cannot be improved. So those issues that we keep on raising, in all these instances that they keep calling for submissions, they need to hear what is submitted. And then to justify why they're rejecting these kind of proposals. And if they're not making sense, they counter with a way that it makes sense. Because when you leave out different kinds of coverages and they propose different kinds, provide different limits, we all have interests. Patients have their own interests, providers have their own interests, business persons have their own interests, private insurers have their own interests. Political players also have their own interests.
Yes.
So these interests are not balanced. We have chaos. Different parties, different groups will feel aggrieved. If it's a person's doing CT scans, MRIs, they push their agenda. Because let's say it's not them, it's a businessman who's brought CT scans and machines and MRIs, and they need to have channel of cases being taken to them. They push for coverage because they want cases to be filmed as quickly as they can, and they need to have the capitations there. So you have a film of CT scan, you will be having a CT scan of 3,500 bob per person.
Yeah.
But then you'll have 2,000 shillings for a household of 4 for dental coverage at 2,000 shillings. So the interest of persons who have teeth or persons who deal with teeth, they'll feel they've been allocated 2,000 bob per year, while the person who's having a CT scan is getting 3,500 bob per instance of a CT scan. These interests are not balanced. And they feel like our issues are not well maintained. So chaos will come up. So interests must be balanced. The project is ours to keep and work with it, whether it's NHIF or it's SHIF. It's doable. In my way, it's doable either way. You can take the good things in SHA and put them in NHIF and still run. You can take whatever you don't want here, take the other side and still run. Either way, there is no loss because you know where you're going. You just want to do healthcare financing. So we are available for consultations, for reviews. We keep speaking about it. So we hope that we get there, because next day I'll probably be unwell. And the card or whatever system with them must work for me and my children. Yes.
Okay, maybe anything in 1 minute.
Yeah, I think my winding up statement is that any law, any policy makes sense when it is implemented, and implemented in the ladder that the spirit that is it anticipates. When we were coming up with the SHA, we had other 3 laws that we are coming up with: the Primary Health Care
and the Emergency
Act, the Emergency, the Digital Act, and we also have the FIF. All these are supposed to complement each other to build a strong health system.
Yes.
And the whole thing is about governance. The whole thing is about the human resource that we have in that sector that can actually ensure that they act with integrity, with discipline, to ensure services is realized. So we want to call for the government. Probably the president might not be knowing, because when they brief, they only brief about positive, they don't tell him about the negative. So he need probably to be listening to the antics, those who can tell him what he doesn't want to hear, so that he correct this thing. If indeed this is one of his flagship project that he want to tell Kenyan that when he goes home he want to be remembered with, then we feel that probably it may take long for any Kenyan to appreciate that. Having said that, it is key to note that we as healthcare workers, our work is about the health of Kenyans, and we must continue speaking about it. Where it's not going well, we must criticize it. It's not that we are against it, but we want them to listen to us so that they correct those misgivings, so that then we can realize services. When I'm seated in a health center, when I'm seated in an outpatient, when I move around and I find facility without healthcare workers, I already know the gaps. So we must speak to these gaps and say, please, we do not have enough human resource, please employ. Even if you collect all the money from all Kenyans and you have the money, the people who justify that end, what you expect is the healthcare workers. Please, they need the support. So currently, and I know like KMPD have already pronounced themselves, we need to see the government that is responsive to the concern of the healthcare workers, so that then you do not just sit there. Health is a complex thing. You need to be thinking while walking. You need to be thinking as you work. You cannot go just sit, operate from boardroom and think that you are running the healthcare. We will continue having a lot of problems. My last call to this, that the fragmentation administrative levels that we have, which was established under the Constitution, it is really affecting our implementation of all the laws, including this SHA, will be affected by the counties and the national level because of not agreeing into specifics and how to act. Until we rethink and agree to the call for the healthcare workers that we need to see the aspect in the health sector that we need to centralize for us to realize, or rather to be efficient in service delivery. That will not work. We will continue aspiring and continue wishing. Yes.
Okay, we have come to the end of Center Stage today on the tackle, the edition of Center Stage, and I was joined by George Maroah, the Secretary General for Kenya Union of Clinical Officers, and Dr. Kahura Mundia, who is the Deputy National Chairperson for KMPDU and who is also a health lawyer, right? Thank you so much for coming, gentlemen. My name is Pheona Kenga. Goodbye. See you tomorrow. God bless.